Ready to start. Welcome to ASCP's Best Practices in NSCLC Biomarker Testing video conference series. Today's session will focus on standardizing protocols for optimal procurement, fixation, and tissue cytology specimen handling for NSCLC. My name is Dara Oken, and I'm a learning experience designer at ASCP, and I will be facilitating today's session. Today's session is developed through a commercial sponsorship from Genentech. This ASCP Genentech initiative is aimed to support anatomic pathology managers and their teams in building community and providing effective resourcing to drive biomarker testing, continuous quality improvement on behalf of patients. We actually have people who are registered tuning in from all over the world. Looking at this, we can see who is here. In this group, the majority of attendees are pathologists from community hospital settings, but our group really represents professionals from many components of the field who bring just a wealth of experience from many interrelated yet unique contexts. Oh, wow. Romania, New Jersey, far off in New Jersey, and others. Okay, before starting, I'd like to tell you about an individualized companion component to the video conference series that we will touch on today. This action plan is designed to assist you in improving your NSCLC biomarker testing processes and workflows. It's a tool that will hopefully be able to help you create a clear path for attaining your patient-centric goals. So this working document can be updated over time as you define your goal, identify steps to achieve the goal, explore barriers, and develop a plan to move beyond these obstacles, all while tracking your progress toward your goal. Ideally, today's presentations and discussion will help you jumpstart this process, and ideas generated could form the basis for your individualized action plan. I'll tell you a little bit about the format we're using today. Following the journey of the lung cancer cell, we'll first hear from Dr. Lonnie Yarmus, who will share his expertise in lab processes and provide a practical approach to specimen and cell collection for NSCLC. Following his presentation, Dr. Zara Maleki will share her expertise in best practices in specimen handling and analysis for NSCLC. Last, we'll separate into breakout rooms where you'll have an opportunity to actively participate in small group discussion related to applying best practices in your own lab setting, as well as strategizing ways to overcome obstacles. A little bit more about the interactivity. We'll dedicate a few minutes after each presentation for questions and comments. And the most interactive component will follow the two presentations when we shift into small groups to discuss what's most relevant in your lab context. So we'll capture highlights of the ideas generated in note form for the resource hub, as well as continue the discussion on our Facebook group. A few final reminders: please keep your microphone on mute until you raise your hand to speak during question times. And also, please do not share any protected health information or personally identifiable information about patients. So now let's welcome Dr. Lonnie Yarmus to today's NSCLC video conference. Dr. Yarmus is the clinical director in the Division of Pulmonary and Critical Care Medicine, as well as an associate professor of medicine at Johns Hopkins Hospital. He'll be sharing his expertise in lab processes and practical approaches to specimen handling. I'll now turn it over to Dr. Yarmus to share his slides and begin.
Thank you. Okay, well, thanks to the ASCP and Genentech for inviting us to be here. Appreciate the intro. I am an interventional pulmonologist at Johns Hopkins, so I guess one of my disclosures, aside from that listed here, is I am not a pathologist. I am chairing the ACCP Guideline Committee for the same topic, and I'm compensated to give educational talks. So what I really want to concentrate to start off here is what we do on the procedure end in our collaboration with our pathology colleagues to highlight, I think, some of the important aspects of our success and how we've been able to achieve a very low QNS rate, and how we think that's easily adoptable in the community. To start, I think the audience is going to be quite familiar with this, but lung cancer, when I started, was we initially were asked, can you diagnose lung cancer, and then small cell or non-small cell, and then adeno or squam. And now really the question to us is not, will you get an answer? It's, can you make sure you have enough tissue for biomarker analysis? And that is the presumption going into these types of procedures, that we will obtain that information to allow for the appropriate patient journey. You can see what's happened over time. A few years ago, we were talking about EGFR, EML4 ALK, and KRAS, and now that list has almost logarithmically grown, and that's due to the fact that these are now well aligned with approved and emerging targeted therapies for treatment. So in order to get there, my job on the procedure interface side is to ensure that tumor sample quantities are sufficient to support these multiple diagnostic analyses. And the education and communication lines to ensure that happens is incredibly important. In the pathology realm, you folks all know this, on the diagnostic end, it's not necessarily well known throughout. So educational efforts like this are incredibly important, as are multidisciplinary conversations throughout your own institutions to educate, proceduralists, surgeons, interventional pulmonologists, radiologists, that, these tests are needed and should be ordered. And understanding that there are multiple pathways that are needed for these samples. So there's the H&E to confirm the cancer. Now there's, standardized IHCs to look at things like Pdl1, and then biomarker analyses for targeted therapies. In order to get this and achieve these specimens, there have been significant advances in the field. Hopefully, most of you are familiar with bronchoscopy, a scope through the airway. The big innovation here is endobronchial ultrasound, which is, if you're not familiar, I'll show some slides, but just a scope with an ultrasound of the tip that allows us wide access to the mediastinum and hilum with direct visualization and sampling. The prior gold standard was mediastinoscopy, or surgical mediastinoscopy, which is also well known. One of the advantages of EBIS, there are many, but one of the main advantages is the safety profile and access, and minimal invasive nature of the procedure when you compare to something like mediastinoscopy. EBIS came out a little over 10 years ago, maybe a little bit longer than that now, but when we started our program at Hopkins, we were doing about 1,000 staging mediastinoscopies a year. And last year we did about 1,500 EBIS and I think around 10 primary staging mediastinoscopies. So you can see that that platform has really changed dramatically. Other technologies are available, like CT guided biopsy, and we'll talk about that, and disadvantages and advantages of a procedural interface like that. And then there's a growing rapid platform for liquid biopsy and circulating tumor DNA. For small biopsies and tissue, the guideline recommendations really speak to small biopsy and cytology specimens. There are, as I talked about, two main ways of doing that now: EBIS TBNA and CT guided or transthoracic needle biopsy. One incredibly important piece from my end is what separates those two is EBIS's ability to stage and diagnose. So a CT guided biopsy is an outstanding procedure to go after a primary lung nodule or lung mass, but it's not typically used for mediastinal sampling, just given the risk and depth that the needle would have to penetrate. EBIS, on the other hand, can do both. So we can access lymph nodes, we could diagnose and then end stage all in the same procedure. The important piece on both ends, and all guidelines recommend this, is that the concept that core needle biopsy is a necessary component should not be thought of anymore. There is ample and robust data now looking at fine needle aspirates as a primary driver to obtain these samples. And I'll talk about how we do that and why we've been successful. One of the big pieces that you'll see in all of these guideline recommendations is that ROSE is recommended when available. And for us, it's an incredibly important, if not the most important aspect of our procedure, because it allows instantaneous feedback to ensure that we have an adequate sample, that we understand the degree of necrosis in that sample, and that we're able to achieve an adequate specimen for biomarker analysis. We're able to do that with EBIS, and just briefly, for those not familiar, this is the scope. It's a very small scope. It's about the size of a pen. And at the tip there in panel A is the ultrasound hub. And then you can see through the working channel, we're able to put a needle right down through the airway. There was earlier concern that this might be dangerous early on in the world of TBNA. This is an old study and actually an old display that I found at Hopkins years ago, where they, from 1954 to 1963, actually did the first left heart caths. And they did that before there was real technology like there is today for interventional cardiology, allowing for flexible catheters. We only had rigid instruments. So this was actually done, pictured here with that rigid bronchoscope, which is a steel pipe placed through the airway with that very rigid needle that's shown there. These are some of the original sketches, and what were done here pre-mitral valve surgery is patient was anesthetized and a rigid scope was placed down through the trachea into the left mainstem bronchus, and you can see the panel on the left, right adjacent posterior to the left mainstem bronchus is the left atrium. So a large 15 gauge needle was passed into the left atrium, and a transducer was then placed to measure valvular gradients. Important thing here, and the message is, in this study back in the 50s, there were over 700 patients that went through this study. There were no bleeding complications. So if we can stick a large needle into the heart, we can safely stick small needles into the mediastinum for sampling. And this is how we do it. Panel A is station 7 lymph node. You can see that white line there. That's the needle under ultrasound going directly into the lymph node. So we know definitively that we're in there. And B and C, I think, are very important in our world. This is a much different approach than most centers. We do not put our specimens in a liquid medium. We use what we refer to now as a clot technique. So the sample is taken directly from the needle. One small drop is placed on a slide, and the diff-quick stain is done for rapid H&E. And then the remainder of that sample, as shown in panel B, is pushed out with the stylet onto filter paper. And with a median of 5 passes, generally, we are able to produce a clot that is shown in section C, and then can be embedded in paraffin and dissected out to, as you can see in D, where you end up essentially with almost a histologic specimen. And this is what we believe to be our main secret, where our QNS rates are below 5%. The factors that contribute to that obviously go beyond just the procedure, right? So there's the adequate sample of histologic sectioning. Necrosis is a main confounder, and that's where ROSE really plays in nicely, in that we have this robust communication between, in our case, our cytotechnologists and us to say, yes, the sample is adequate, yes, it looks diagnostic, and either yes or no, there's a lot of necrosis, or not, driving how many samples we need. Same with low tumor cellularity. If it's a robust sample, but there's not a lot of cells, we will keep going. So there are some passes where I take one pass, we look at the slide, it's packed with tumor, and they say, give me 1 or 2 passes and we're good. More often than not, it's 4 or 5, 6, 7, whatever is needed. And we'll do that to really get our QNS rates as low as possible. This is now well adopted, CAP, ISLAC, AMP, all the guidelines recommend analytic methods chosen to detect samples and mutations to limit QNS rates. Again, briefly, Rose is in my opinion, the most important aspect of our procedure. My expertise in the procedure, I don't think is nearly as important as the quality of our Rose technicians at Hopkins. Some centers use pathology, some use cytopathologists. Ours are cytotechnologists. They're amazing. They're well experienced. As I said, it allows for preliminary diagnosis and downstream biomarker testing, and rapidly decreases the need for rebiopsy. And then finally, I'll just realign the fact that these samples and the way they are collected are well established in guidelines. So listed here is a recent published guideline that we were part of, multi-societal, including CAP and AMP, showing that, again, these cytologic specimens are useful, successful, and should be done. And they should be acquired through minimally invasive techniques due to the fewer risk complication profiles. So I will stop there and stop sharing my screen here.
Thank you so much, Dr. Yarmus. Let's open the floor for questions or comments. If you'd like to share a challenge you face or a lesson learned, please click the reactions near the bottom of the screen and select raise hand so we can call on you. I see a question in the chat.
Can you hear me? Sorry.
Yes.
Okay, so what do you use for fixation of the EBILS TBNA specimen?
Yeah.
Like you showed in the picture, it's a pretty big specimen, like the cost. So.
Yeah. So great question. So what we do is first drop is put on a slide, and that we use that for the rapid analysis. And then we use the stylet and push out the remaining sample onto that filter paper, and then repeat the pass and continue doing that. Once, typically 4 to 5 passes will give a clot of that size. That is then put in formalin and analyzed from there. I'll defer to Dr. Manike from our pathology department for specifics there. But that is in our opinion a big advantage of what we do. We're actually doing a randomized controlled trial now, where we look at Rose versus no Rose and clot versus a liquid medium, which at our center is Cytolite. But we do think that the clot technique is really one of the major drivers for our low QNS rates.
And about the trial that you said about, what would be the liquid medium that you use for the other arm, probably?
Yeah, so we use Cytolite as our standard medium, and having now being on this ACCP guideline, there's a wide variability in centers. Some people primarily, initially put it in saline or RPMI or formalin or, an alcohol-based fixative. I don't believe there's really much data showing advantages of one over another. We think, again, it's going to be that cellularity piece through the clot technique and binding of those cells off that filter paper and wicking away, much of the mucus and sputum and blood that allows sort of a tighter congealed specimen.
Have you ever forced, let's say, or did you send away any specimens and you needed fixation and transport medium? And what would be those if you need to send away the specimen? Because in our country, not always the procedure is done in an institution that can do also the pathology aspect of the testing, So sometimes the specimen need to be sent away to a different location where they do the pathology and molecular testing.
So I will defer to my pathology colleagues there. I believe it is paraffin embedded. And then it can be handled much like the standard pathologic specimens.
Yeah, thank you, Dr. Yarmus. Thank you for your presentation, and thank you for the question. In confirmation of Dr. Yarmus, yes, there are different approaches. If you would be able to actually do the processing of the tissue and send formalin fixed, paraffin embedded material, I think probably that's the best way, because having block would be much safer in terms of transportation than transporting any type of fluid in general. And so that can be simply done, I think, in any labs, and then you actually send, the cell blocks. So I think that's probably the best way.
Thank you.
Wonderful. Thank you so much for wonderful questions and both expert responses. Due to time, let's move on, and we would like to introduce Dr. Zara Maleki to today's video conference. Dr. Maleki is an associate professor of medicine in the Division of Cytopathology, Department of Pathology at Johns Hopkins Hospital also. She'll be sharing her expertise, as she already has begun to, on best practices in specimen handling for NSCLC. I'll now turn it over to Dr. Maleki.
Thank you so much for your kind introduction, and I appreciate the ASCP and also Gentech for inviting me today. And let me share my screen with you. Okay, so we are going to continue our discussion with best practices in specimen handling with a focus on a real case. As you notice, I have no financial conflicts to report. So the aim of pathology evaluation is to render an accurate diagnosis using 2015 WHO classification, and to ensure that there is sufficient material for molecular studies, especially in patients with advanced stage lung adenocarcinoma. NCCN constantly update their website in terms of management of the patients with lung carcinoma. And it's very important to give a diagnosis for non-small cell carcinomas, either they are squamous cell carcinomas, other adenocarcinomas, or other types of non-squamous, non-small cell carcinomas. And based on that diagnosis, then there are some recommendations for molecular profiling of those carcinomas. And as you notice, in terms of recommendations, there are some of those gene mutations that are called category 1, and some of them, you really don't see that. So those cases that is called category 1, it means that if your specimen is minimal, that's the minimal things that you have to do, and you always have to start with those first. EGFR and ALK1 are among category 1, and also Pdl1 testing for both adenocarcinoma and the squamous cell carcinoma is considered as category 1 as well. Now the question is, why should we do this molecular testing? What is the significance of that? And why we are just choosing a specific type of genes for evaluation of molecular alterations? The answer, of course, is kind of simple, because for those molecular alterations, now actually there are some sort of treatment. So that's why we are calling those as actionable mutations. And as you see, this list is going to get longer and longer. For example, Pdl1 was just added just a few years ago, and now the patients actually can benefit for that treatment related to Pdl1 if they show expression of Pdl1. It's interesting to know that only a subset of non-small cell lung adenocarcinomas actually show actionable mutations. For example, ROS1 is seen only in 1% of non-small cell lung carcinomas, while EGFR is more common, and you will see in 10 to 35% of the patients. Now, in terms of category, we mentioned about the category 1 and category 2. Moreover, you see also, as Dr. Yarmus mentioned, different societies and different institutions, they are all engaged and involved with management and also treatment and the specimen processing for non-small cell lung cancers, including College of American Pathologists. In 2018, they added new recommendation, and that includes that in addition to cell blocks, now any other type of cytologic preparation is usable for molecular studies, and that was a big move. And also, the analytic methods must be able to detect mutation in a sample with 20% or more malignant cell content. So that also, sheds extra light in terms of what we should do. Now, there are different types of molecular studies. Next generation sequencing, which is widely used, and actually it covers a broad-based panel. Also, there is another type of NGS, which is RNA-based. It maximizes detection of fusion events. PCR, it's more suitable for a specific targeted fusion. And of course, FISH, a more specific method when it comes to examination of copy numbers, amplification, and structural alteration. And it's important to know that each one of these methods can be DNA-based, RNA-based, and also they can work with variable amount of DNA content, which is actually is important. Pdl1, let's just have a little bit of introduction about Pdl1, which is also called as programmed death ligand 1, which is a co-regulatory molecule. It's expressed on tumor cells, and it's inhibiting T-cell mediated cell death. On the other hand, there is PD1. PD1 is a negative regulator. It binds to ligands, and it's actually, you can find it on T cells. So those immune checkpoint inhibitors, they block the interaction, that PDL1 and PD1 interaction, and therefore they enhance anti-tumor effects on T cells. The recommended method for Pdl1 evaluation is actually IHC. Here is an example of IHC. The immunostaining is actually FDA approved, and it goes based on tumor proportion score. As you see here, slide 1, there is 0% of expression. When it comes to the last slide, actually you see 100% expression, and in between is kind of variable. So specimen adequacy, that's the most important thing. As Dr. Yarmus mentioned, we use rapid on-site evaluation, and that is done by experienced cytotechnologists. So any cytotechnologist before starting EBOS should go under extensive training, additional training at the hospital to become familiar with all steps and also be very efficient. So for each pass, 1 drop of the specimen is used for air drying, slide smear, which is used for DIFQuick for on-site evaluation. The other smear would be immediately put in alcohol fixation, and rest of this needle as needle material, as Dr. Yarmus mentioned, they put it on a paper towel to actually create the clot. So sometimes the patient might be a referral patient, or the previous material might not be adequate for molecular testing. So upfront, we may know that this patient specifically needs molecular testing. We communicate with our pulmonologist, and therefore they also giving us more material with knowing that this is actually going specifically for molecular testing. Usually, as you are aware, EBOS TBNA cases come in multiple parts, and we learned in our practice that it's much better if we triage our cases on same day. So as soon as we get the material, we look at the cell block. If we have to order immunostaining, actually we do it at the same day. We try to keep our turnaround time as short as is possible. I would say it varies between 1 to 3 days. It depends on the day of the week and also the complexity of the case and immunostains that we are going to order. As you see on this diagram, non-small cell carcinoma that we try to handle is just very individualized, and you are trying to basically handle one case at a time specifically. So when it comes to tissue preservation, one thing that we should remember is exactly like eating a cake. Each person should not have more than one piece, right? So as pathologists, we want to keep just only some part of the specimen when it comes to the diagnosis. So there are several ways that we try to optimize utilizing the tissue. That starts actually through the procedure room with clot method that we already discussed. And also when it comes to cell block, we also found upfront slide sectioning that would actually minimize the tissue waste. So the time that they start cutting the tissue for first time, they also go for 7 to 8 unstained slide, depends on how much material they have. And the other thing is you need a coordination between surgical pathology and cytopathology. In an institution like us, that cytopathology is actually in different building from surgical pathology, that coordination goes through our EPIC system, our data system, to see if the patient actually has a core biopsy or is cell block only. And that's extremely important because when it comes to ordering molecular studies, you are not going to order on both parts. You are going to order either on small core biopsy or on cell block, depends on what you have for your case. The material that we receive, generally speaking, it can be formalin fixed, paraffin embedded of cell block from that clot. It might be small core biopsies. You may have some smears, diff quick stain, Papa Nicolau stain, which is alcohol fixed. And also you might have some cytospin. Those are most commonly type of specimens that we use at our institution, but of course, some other type of specimens might be tissue imprints and also liquid-based preparation. So when it comes to lung carcinoma, it's very important to differentiate between a primary lung carcinoma versus secondary malignancy. And also, if it's lung carcinoma, is it a small cell carcinoma versus non-small cell carcinoma? So one of the things that is routinely used at our institution is actually a lung triple, which is a cocktail of TTF1, napsin A, and P40, which we actually do on cell blocks from these EBOS-TBNA specimen that we receive. I should add that in addition to EBOS-TBNA specimens, we might actually have other type of specimens that they require also the diagnosis for non-small cell lung cancer and also molecular studies, such as serous fluid, especially pleural fluid. Sometimes it might be metastatic sites, such as mediastinal lymph nodes, liver, and other sites. Here, actually, you can see images from non-small cell carcinoma, which was actually adenocarcinoma in pleural fluid. Here it shows very cellular material on cell block and also immunostaining confirmed TTF1, and that was actually a case of adenocarcinoma of the lung. So when it comes to diagnosis and putting the report together, I think there are a lot of details that makes it just like it's very fine line when it comes to reporting cytology. One is diagnosis. In addition to diagnosis, we report our results on lung triple stain, what we see. Also, we found it useful that in our pathology report, we include what we see in our cell block. Do we see sufficient material for molecular studies? Do we see a lot of necrosis? So we include that also in our main pathology report. In addition to that, when we order NGS and Pdl1, we also include that one in our report. So that way, the pulmonologist, the oncologist, the surgeons, everybody would know that for this patient, in fact, we've ordered Pdl1 and we also ordered NGS. Also, if there is any core biopsies, we include in our report that yes, there is a core biopsy, please correlate, and we also give the surgical pathology number in addition. We should keep in mind that our institution, like some of other institutions, we went live in terms of data, so the patients actually can have access to their diagnosis and the findings immediately. So an example of on-site evaluation for lung adenocarcinoma is stained with Diffquick. This is alcohol fixation smear with Papa Nicolau stain. Here is a beautiful cell block. You see very cellular, and lung triple was positive for nuclear staining for TTF1 and also cytoplasmic granules for napsin A. Now the patient, of course, we ordered NGS and also Pdl1, and this is the report for the patient. So all the actual images that you see, they all belong to one patient. So NGS, they actually DNA is extracted from formalin fixed material, and this is actually what you see here. I copied from the patient's report, so you can actually see the amount of information that would be available to the patient. So this patient did not have any BRAF, KRAS, or MET exon 14 mutation. However, they detected EGFR L for L747P on exon 19. And actually that mutation is significant because these patients might have they show resistance to both gefitinib and osimertinib. So that's important. And what happens to this patient next? And you also see that at the end of the report also shows the website that actually the patients can see the type of information that they can find for molecular diagnostics. So next step, this patient had several studies, this time on fusion studies. This time RNA was extracted from formalin fixed paraffin embedded material, and they looked for over 200 specific gene fusion in one single reaction. They did not find ALK, ROS1, or RET rearrangement. Also, MET-FISH results was negative. In addition, patient had Pdl1 studies. This is another example that you see for Pdl1. Pdl1 for molecular studies that you saw in previous slides, they all can be found in electronic data system of hospital, and those actually come as separate reports. When it comes to Pdl1, that would be actually as an addendum to the final pathology report. And as you see, it labels the block that was used for that case, the site which was to our lymph node, and the score was less than 1%, and that shows actually this case was negative. It means the patient would not have benefit with current medications for Pdl1. At this point, I conclude my session, and I appreciate your attention.
We're going to shift into our breakout rooms. So you might remember the reflective questions that you received leading up to today. What aspects of specimen procurement is your AP lab trying to tackle? What's working and what is not? Here's your opportunity to share those ideas, to learn from each other, share success strategies, as well as refine your plan for individual growth. To support your discussions, we're providing you with a few guiding questions regarding specimen handling in your own lab contexts. The hope is that you will designate one person in your small group as note taker who can jot down the thoughts shared in your group, which we will capture. It will show the current issues in the field as well as successes, and we can take those challenges and highlights to later compile them anonymously and share them on the resource hub. So the questions in the Google form are intended to guide your discussions, but please gravitate to whichever question you would like to address. because time is limited, and you'll only have 10 minutes in your breakout room, and we'll come back together for a few minutes, hopefully, for possible questions for Dr. Maleki, maybe share outs from discussions, and a couple closing remarks. So in a moment, you'll receive a prompt to enter your breakout room, and when time is up, you'll be redirected again back to this room. Enjoy your discussions. Okay, it sounds like there were really some wonderful discussions in your small groups. I wish we had more time for the breakout rooms. We only have 2 minutes remaining. We would have wanted to share takeaways from your small group discussions. Ideally, we would be able to do that, but hopefully the takeaway discussions could continue in Facebook group, which I'll tell you about next. Since we're nearing the end of our time here, I want to thank you for your participation. Please take 30 seconds to complete the brief survey you will find in the chat, as we rely on your input to shape future education initiatives, including making more time for ones like these that have the interaction. We'll also invite you to save the date for 2 upcoming video conferences: December 2nd, Key Actionable Driver Mutations in Patients with Advanced NSCLC, and January 27th, Actionable Results and Turnaround Time Indicators for NSCLC Workflows. On the next slide, we'll see the things I am referring to that are part of this educational initiative at the Resource Hub. So with ideas fresh in your minds, hopefully in your discussions, as well as spurred on by the wonderful presentations, you might be ready to start your action plan. If so, please visit the Resource Hub on ASCP's website. Thank you so much to both our presenters and all participants. And at the top of the hour, this concludes today's presentation.